Good morning, everybody. I know this is probably one of the last sessions and everybody's anxious to go to the beach or home. So I'll try to make it as quickly as possible, but by all means, feel free to ask me questions at the end of the session. So endocrine therapy is actually not a new concept. Like ever since the 1800s, it was known that certain tumors, especially breast cancer, are dependent on hormone therapies. Like people used to take ovaries out of sheep, they noticed that some of the sheep that had breast cancer actually had that involute. So since then, an effort to target it, the endocrine therapy targeted treatments has evolved quite a lot. Initially in the form of tamoxifen, and subsequently with the use of aromatase inhibitors, more recently fulvestrant. And now we are trying to add targeted therapies to endocrine therapy to counteract possible resistance to this treatment. There are several types of ER-positive breast cancers. Before we used to think that this was all one basket, but now we know that there's at least two clinical types that are relevant for practice. One of them, if we were to genomically profile everything, which we don't do today from a standard care point of view, but if we could, we would notice that there's two main types. One is called luminal A, which genomically speaking, what characterizes these tumors is the presence of very high levels of estrogen expression, as well as a lower grade, and they are very well-behaved tumors that respond very well to endocrine therapy. On the other hand, the luminal B ones are the ones that tend to have higher grades, lower expression of ER, and they are not so responsive to endocrine therapy, even though under the microscope they may look identical to a luminal A tumor. So I'm going to start by presenting a case study to illustrate some of the things I'm going to talk about today. So this is a 68-year-old female that originally presented with a stage 2 T2N0 2.1 centimeter tumor in the right breast. She had a no special type tumor with some lobular features. This was intermediate grade, a low proliferative rate. She had ER and PR immunohistochemical expression in 80% of the cells, HER2 non-amplified, and this was in September of 2005. At that time, she underwent a right lumpectomy with sentinel lymph node biopsy, followed by radiation therapy, 5 years of anastrozole, and she completed that therapy in November of 2010. In the summer of 2013, the patient developed a hard lump in her right cervical area, and a biopsy of the lump was consistent with the recurrence of her ER-positive breast cancer. She has staging imaging studies with CAT scan of neck, chest, abdomen, and pelvis, and a bone scan that confirmed the presence of multiple lytic bone lesions throughout her spine, ribs, and pelvis, as well as right cervical, mediastinal, and intra-abdominal lymphadenopathy. Aside from the lump in the neck, she's actually asymptomatic. So, what did you recommend at this time from a systemic treatment point of view? Chemotherapy with an anthracycline and taxane-based regimen, endocrine therapy and bisphosphonate therapy, or none of the above? Good deal. So that's definitely the right answer. The reason chemotherapy would probably not be appropriate for her at this point is this patient is asymptomatic. She's definitely not in visceral crisis. She doesn't have disease in any of her organs. And since she has bone metastasis, it would be appropriate to institute some form of bisphosphonate therapy up front. So, right now, this is what the treatment landscape for endocrine-sensitive metastatic breast cancer looks like. So in the big scheme of things, what you want to do with a patient when she presents with recurrent disease is exhaust endocrine therapies as much as you can before committing this woman back to chemotherapy. So theoretically, if possible, we would like to give endocrine therapy in first, second, and even third line of metastatic treatment. The exception to this rule is if somebody is very symptomatic and presents with visceral crisis. So if you have a patient that their transaminases are a little up because of like extensive liver involvement, or they're like in incredible pain, or they have a wound that won't heal, or something that really forces you to have a faster response, at that point it may be more appropriate to consider chemotherapy. But in the absence of any of these features, endocrine therapy really is the mainstay for first, second, and third line. So let's take a little bit of a better look at the breakdown of what do we use in first, second, and third line. So for the very odd patient that presents with metastatic disease de novo that has never ever seen endocrine therapy, there is a SWOG study that combined fulvestrant with an aromatase inhibitor, and that actually showed survival advantage in that particular patient population. So that's something that for somebody that presents with de novo metastatic disease and has never been treated before with any form of endocrine therapy may be an appropriate consideration. However, the majority of patients that we see are patients that have had prior exposure of endocrine therapy in the adjuvant setting, either from a short period of time, from the time they were diagnosed with a metastatic disease and finished their adjuvant therapy, or many years thereafter. So for patients that had a recurrence many years after completion of endocrine therapy, it wouldn't be unreasonable to consider either a first-line AI, that could be AI of your choice. There's some studies, like the first study that suggests that maybe it would be reasonable to consider fulvestrant as well, although this is not widely accepted. And nowadays, we have new targeted therapies that were recently approved by the FDA, but yet not quite used. But potentially one could get a hold of a CDK4/6 inhibitor and add that to endocrine therapy in the form of letrozole and palbociclib. Now, there's also several clinical trials ongoing now with targeted therapies in combination with endocrine therapy. For first-line patients that have had a recurrence short time after completion of adjuvant therapy or during their adjuvant therapy, which is what we call a primary resistance to endocrine therapy, it would be appropriate to consider either an AI or fulvestrant by itself. You could still try that, or you can combine an aromatase inhibitor with everolimus, which is an mTOR inhibitor, that based on the Bolero-2 trial, it would be appropriate to consider that in an attempt to reverse this endocrine therapy resistance that these patients may have gotten. That can be done in combination with tamoxifen, that one could consider a combination of an AI and a CDK4/6 inhibitor, or fulvestrant by itself, or again, other clinical trials. For patients that present with second and third line of therapy, obviously clinical trials is something that we always think about, but again, combinations of targeted therapy and endocrine agents are becoming a little bit more popular, but it's not wrong to also use single agent, either fulvestrant or another AI. So we'll move on to another question. So going back to the case of that patient, her oncologist went ahead and started her on letrozole and IV zoledronic acid in August of 2013. Her disease remained stable till April of 2014, so she had actually a good run with her AI, which is kind of like to be expected, so definitely more than 6 months benefit from her AI. And now her restaging scans revealed an increase in the size of her lymph nodes and 3 new bone metastases. She continues to be asymptomatic. So how would you characterize her response to endocrine therapy at this point? As primary de novo resistance, secondary acquired resistance, I don't have enough information to determine this, or I have no idea what I'm talking about. So go ahead and answer. Perfect. So indeed, this patient does have what we call a secondary resistance. The reason that is the case is this is a patient that recurred with metastatic disease many, many years after her original diagnosis, and definitely many years after she has completed her adjuvant therapy. And within the metastatic setting, she's had benefit from endocrine therapy for more than 6 months. So this is definitely what we would characterize as a secondary acquired resistance to endocrine therapy. So, this is actually an important concept that I would like to go over today, because I think that actually does help us make decisions of what is going to be our next line of treatment for these particular patients. So as I said, primary de novo resistance are those patients that they either recur with metastatic disease while they're getting their adjuvant therapy or shortly after completed that within the first 6-12 months of completing adjuvant therapy. And the secondary resistant ones are the ones that have had benefit from endocrine therapy in the adjuvant setting and in the metastatic setting, and now their cancer is misbehaving. This is a totally different biology of disease, because the de novo resistant, the primary resistant, these are probably those quote-unquote luminal B cancers that really never responded to endocrine therapy to begin with. So perhaps for cancers that behave like that, it may not be appropriate to consider a first and second and third line of endocrine therapy unless it's in combination with other agents that may potentially reverse that resistance. Whereas that patients that have secondary resistance, that is a tumor that is much more dependent on endocrine therapy than anything else. So in those patients, actually considering 3 lines of endocrine therapy even by itself may actually be appropriate. I'll say that about 50% of the patients with ER-positive metastatic breast cancer do not respond to initial endocrine therapy. And the majority of patients will ultimately progress despite endocrine therapy regardless, either because of primary or secondary resistance. If you analyze these tumors genomically, as you can see here, and again, you don't have to read anything here, but it's easy to notice that cancers that are sensitive, they practically don't have any genetic abnormalities, whereas cancers that are resistant to begin with, look how much is going on. So these are busy tumors that have figured out other ways to survive and grow and proliferate regardless of estrogen stimulation or not. So acquired resistance has been studied in the laboratory for many years, and a few things that jump up is that there are certain pathways that are more associated than others to the secondary resistance. So the cancers that have responded initially to endocrine therapy but then stop at some point. And the one that comes to mind is what we call the PI3 kinase pathway. And that's going to be important later on when I show you some of the clinical data with some of the agents that tackle that particular pathway. The PI3 kinase pathway is what we call a survival pathway. So obviously it's an important avenue that these cancers figured out how to tap into to continue to stay alive regardless of estrogen stimulation. Whereas with de novo resistance, the biologic basis seems to be a little bit different. Sometimes we can see loss of ER. Sometimes we can see loss of amplification of co-amplificators, receptors. And sometimes we can see cyclin D pathway components being altered as well. So again, this is going to be a little bit more important when we talk about some of these newer targeted therapies that tackle the cyclin D pathway rather than others. So let's talk a little bit about these ESR1 mutations and acquired resistance to anti-estrogen therapy. So these mutations are something that for the first time this was described was actually many years ago, but because nobody could actually replicate it at that time, it was poo-pooed for a long time. Until recently, when we found that these mutations are actually real and definitely associated with resistance to conventional endocrine therapies as is. So there are several different point mutations that have been described at this point. And the thing that's unique about this is the detection of these mutations is only present after a patient has been exposed to endocrine therapy. It's incredibly unusual, I wouldn't say impossible, but incredibly unusual to see this in the early setting. So if you were to profile a tumor for somebody that was just diagnosed with breast cancer without having ever been exposed to endocrine therapy, you would not find these mutations. So the sine qua non condition here is you have to have a patient that has seen endocrine therapy before you can find some of these mutations in the tumor. So this becomes important when now we have possibly novel agents coming about that are being studied to target ER possibly in a better way that could tap into some of these mutations as well and be effective against them, whereas the conventional aromatase inhibitors, fulvestrant and tamoxifen, do not do that nowadays. So as you know, the endocrine therapy choices for us nowadays include SERMs like tamoxifen, SERDs like fulvestrant, and aromatase inhibitors. They have a little bit of a different mechanism of action, but the bottom line of what you're trying to do essentially is suppress estrogen production, either primarily in the ovary or indirectly in the skin and adrenal glands. So there are now certain drugs that have a much higher affinity for ER, and there are new selective estrogen receptor downregulators, such as this drug called ARN-A10. This is a drug that, in simplistic terms, think of it as a super fulvestrant. It has a much higher affinity than fulvestrant in the way it binds to estrogen, a much higher potential of degradation than fulvestrant does. So what the preliminary preclinical data has shown is that in tumors that have ESR1 mutation, this drug is active, whereas medications such as tamoxifen and fulvestrant are not. So clinically, this is obviously relevant because potentially this is a drug that if you have a patient with an ESR1 mutation, that patient may not respond to the conventional tamoxifen, fulvestrant, or AI, but may respond to a drug such as this one. This is now actually in phase 1 clinical trials and currently ongoing phase 2 clinical trials, and hopefully shortly will be available in phase 3 clinical trials. But it remains yet to be seen if this is going to be superior or at least equal to the current therapies we currently have available. So this is just a little picture of the phase 1 And stay tuned because I think we're going to hear more about this drug in upcoming meetings such as ASCO and San Antonio. So let's go back to that patient that we were talking about before. So as I said, this woman now has disease progression. And we talked about primary and secondary endocrine resistance. Now it's time to talk about what we're going to do with her. So what therapy options are reasonable at this time? We have fulvestrant, tamoxifen, exemestane, and everolimus, chemotherapy with an anthracycline taxane-based regimen. All of them are acceptable except for bullet point D. Great. So indeed, A, B, and C are reasonable choices for her at this point. So switching endocrine therapy or adding a targeted therapy to her endocrine therapy is a very reasonable choice. I still think chemotherapy would be unreasonable at this point, considering this woman still doesn't have metastatic disease in her organs and continues to be completely asymptomatic. So nowadays, in order to tackle resistance, aside from resistance such as ESR1 mutations, which again are fairly uncommon and should potentially be tackled with stronger estrogen blockers, such as potentially these new drugs or whatnot, there are several growth factor pathways that have been studied as potentially being adjuncts to endocrine therapy, like when you inhibit those pathways. So as you can see here, there has been clinical trials and preclinical data done with EGFR and HER3 inhibitors, FGFR inhibitors, IGF inhibitors, MET inhibitors, PI3 kinase inhibitors, epigenetic regulators, MAP kinase inhibitors, and CDK4 inhibitors. So you can find preclinical data and clinical trials with every single one of these class of drugs in order to circumvent resistance to endocrine therapy. However, for the purpose of this talk and time, I'm going to focus on a few of them, namely the PI3 kinase inhibitors, the CDK4/6 inhibitors, and epigenetic regulators. So let's start by talking about the PI3 kinase pathway. As I said before, this is a pathway that we also call survival pathway. It interacts with a number of things. I mean, obviously within a cell, all these pathways crosstalk with each other, so you block one and the tumor figures out how to activate another. But nevertheless, the activation of this pathway is associated with malignant transformation, tumor invasion, enhanced angiogenesis, enhanced survival of the tumor, and drug resistance. The PI3 kinase pathway, when overactivated, that can happen either via alterations on the genes, that could be in the form of mutation, amplifications, or whatnot, or they can just be overactivated and I really don't find anything wrong with it. But be it as it may, when you look at the breakdown of at least genetic mutations seen there, you can see that at least PIK3CA mutations, which is the gene that encodes for PI3 kinase protein, especially the alpha subunit, which is the most relevant one in breast cancer, you see that for ER-positive breast cancers, almost 35, if not 40% of those cancers may have a mutation on this gene. When the mutation is present in the early setting, and the cancer may be born with this mutation, interestingly enough, these cancers actually behave better. If you look at all these graphs, they're all very busy, but all of them show the same thing. The top line is associated with like a better outcome, and cancers that have the PI3 kinase mutation invariably do seem to have a good prognosis early on. However, when you look at a tumor after the tumor has been exposed to endocrine therapy and see what happens when they have an overactivation of the pathway, the behavior of the tumor, the natural history of the tumor at that point is really not so good. So there seems to be a little bit of a dual role for these PIK3CA mutations or PI3 kinase pathway activations in early versus late estrogen-positive breast cancers, where in early breast cancers, these PIK3CA mutations may be a marker of a tumor that's very, very dependent on hormone therapy. They're relatively indolent tumors, but the ER and PI3 kinase signals may actually cooperate, but ER is dominant. Whereas when you're dealing with a patient in the metastatic setting, where the patient already has been exposed to endocrine therapy, it's possible that these PIK3CA mutations may behave as a mechanism of anti-estrogen resistance. So Preclinically, this pathway definitely has been associated with resistance more than anything. But the reason for that is most of the preclinical data is being done in cell lines that already have been exposed to endocrine therapy. So it's really tackling that potential secondary resistance that these cancers may have developed. And that's why the PI3 kinase pathway really is more relevant for patients that have had a good response to endocrine therapy rather than something you'd use up front. So the first study that actually showed that clinically was a study called TAMRAD. This is a phase 2 study for patients that were essentially postmenopausal. All of them have had exposure of aromatase inhibitor in first-line metastatic setting, and at that point they were randomized to receive either tamoxifen alone as a second line or tamoxifen plus everolimus, which is a TOR inhibitor, which is the most downstream node in the PI3 kinase pathway. And what we see is that overall, the group benefited from the addition of everolimus. However, when you break down the data and look which part of the group benefited the most from the addition of everolimus, you see that the patients that had primary hormone resistance, meaning the ones that didn't have well-behaved tumors to begin with, had minimal response to their first line of endocrine therapy, did not really benefit that much from the addition of everolimus, whereas the patients with secondary resistance are the ones that really drove the benefit for the overall patient population, where the breakdown of the curves is actually quite impressive, and the ones that had the addition of everolimus in there had a much better progression-free survival. This was to some extent replicated on the Bolero-2, which is the phase 3 trial analyzing the addition of everolimus to aromatase inhibitor for patients that were postmenopausal and exposed to prior endocrine therapy. So again, all these women have had at least 1 or 2 lines of endocrine therapy before. All of them had to be exposed to a prior aromatase inhibitor. And at recurrence, they were randomized to receive either exemestane, which is a steroidal aromatase inhibitor, with placebo, or with everolimus, which was the drug of interest. Within this trial, they actually genomically tested a lot of these cancers. And what they've seen is that a substantial proportion of them, as expected, had a PIK3CA mutation. Almost like 50% of these cancers had that. Other things that were also found abnormal were components of either the cyclin D pathway or FGFR pathways or p53 losses and whatnot. However, when the data was analyzed, the overall benefit was really in all populations regardless of what genetic alteration was present there. Pretty much everybody benefited from a progression-free survival regardless of primary or secondary resistance or regardless of genetic alteration. And that obviously generated a lot of excitement, and to make a long story short, based on this data, the drug was approved by the FDA and is currently available for use in the general practice. However, somewhat recently, we saw the results of the overall survival data from this trial. And unfortunately, this was a little disappointed where the addition of everolimus to exemestane did not confer overall survival benefit for this patient population. Now, there can be a number of reasons for that, and probably the most obvious one is these are patients that after participating in this trial, God knows what they could have been exposed to before. And once the drug was approved, maybe they got exposed to the drug later on in life. So I think it's a little hard to show overall survival data or overall survival advantage in endocrine sensitive patient population, but nevertheless, my take-home message from this data is the following. It's one more option we have. Do we absolutely have to expose patients to everolimus? No. I mean, I don't think patients are missing out on anything if you don't, but if the patient is not motivated to get chemotherapy, they don't want to come in for infusion, it's one more option you have in there. Like anything in life that we do in terms of deciding what to treat our patients with, it's still, the decision on that is still going to be ultimately driven by quality of life, palliation of symptoms, and goals of survival. If you want the patient to perhaps not have like an improved, like a much more, improved survival, but yet a better quality of life. So the drug has some side effects, mucositis being one very annoying one, but nevertheless it's oral, it's convenient. So again, I think it's definitely an option, and for patients that have secondary resistance and have been exposed to endocrine therapy before, it's not unreasonable to consider this. How about the same strategy, quote unquote, in first line treatment? So this is another phase 3 trial with a different mTOR inhibitor called temsirolimus. This is an IV mTOR inhibitor that has somewhat a little bit of a different activity than everolimus does. And this is a phase 3 trial that randomized patients that were presented with first-line treatment to letrozole with placebo or letrozole plus temsirolimus. And essentially what was seen is that neither progression-free survival or overall survival was impacted by this strategy. Again, the main differences between this trial and Bolero was, the obvious one is a different mTOR inhibitor. But the most important thing is this is a completely different patient population. This is a patient population that has not seen endocrine therapy before. So it is conceivable that a lot of these women did very well with just estrogen-targeted therapy without really needing the addition of something else in there to have done okay. So to me, the patients in which I would consider adding an mTOR inhibitor are the ones that have already shown you that they are not responding so well to endocrine therapy. So to me, this is definitely a second or third line treatment choice. Now, preclinically speaking, one thing that we found is that when you block mTOR, especially TORC1, which is one of the subsets of the mTOR molecule, which is what everolimus and temsirolimus block, what you may see is a feedback loop that activates AKT, which is actually a powerful node in the PI3 kinase pathway. When you activate AKT, you may actually signal through other pathways that may make the tumor continue to proliferate regardless of what you're blocking downstream. So one potential way to reverse that is instead of using something that blocks the PI3 kinase pathway downstream, is blocking it upwards, either in the form of blocking TORC1 and TORC2, so blocking all components of the mTOR molecule, or doing a PI3 kinase and a TOR inhibition. So that's how now newer drugs, either PI3 kinase inhibitors or AKT inhibitors, are now in clinical trials to see if they will perform at least equally, if not better, than mTOR inhibitors do. So there are several PI3 kinase inhibitors now in the market. Some of them are better tolerated than others. The more things you block, the more toxicities you see, as you can imagine. So if you block TORC1 or TORC2, or if you block both PI3K and mTOR, what you end up seeing is that the toxicity profile is it's something that you have to tackle. And it's not just mucositis, it's mucositis, hyperglycemia, GI issues and whatnot. So for the most part, the class of drugs that kind of has moved forward between all this slew of things here are the medications that block PI3K. The AKT inhibitors are kind of like so moving along just because of their toxicity profile, and these dual inhibitors are also not doing that well from a toxicity profile. So the pan-PI3 kinase inhibitors, or the ones that are PI3 kinase selective inhibitors like the alpha subunit or the beta sparing subunit ones, are the ones that are most advanced in clinical trials nowadays. So what our group at the Interbuild has done is explore some of these inhibitors preclinically to see where and with what would it make sense to combine these drugs with. So Todd Miller, who was, now he's moved, a very talented postdoc in Carlos Arteaga's lab, he's created these cell lines that are estrogen receptor positive, and they're incredibly resistant to endocrine therapy. They grow completely independent of estrogen being there or not there. They're just like bulldozing all over the place. And he exposed them to a number of different medications. And when you see here, these black bars, essentially they are tumor proliferation. And what you can see is that of all the things he's exposed these drugs with, including everolimus, which is here, red 001, seen here, the thing that actually made these cancers grow the least was a PI3 kinase inhibitor. In this case, what he used is a drug called BEZ235, which is a dual PI3 kinase mTOR inhibitor. But literally, again, of all the things that they exposed these cancers to, the PI3 kinase inhibitor really was the one that performed the best in the setting of estrogen resistance. And in xenograft models, when you combine a pan-PI3 kinase inhibitor called BKM120, which nowadays we know as buparlisib, with fulvestrant, again, the tumor suppression was unbelievably impressive when you combine both drugs rather than none or each one of them individually. So that was the basis of creating several clinical trials combining PI3 kinase inhibitors with endocrine therapy. The first one to be reported was a phase 1 trial that was also led by our institution, and it was done in collaboration with the Stand Up to Cancer team, which was a phase 1 combining buparlisib, this pan-PI3 kinase inhibitor, with letrozole for patients that were resistant to endocrine therapy. So all these patients have had exposure to endocrine therapy as their first-line treatment in a metastatic setting. And what you can see here is that we had 2 cohorts of patients, the ones that received the drug continuously, and the ones that received the drug intermittently, meaning 5 out of 7 days. And the reason we explored that was to assess if there was a little bit of a difference in the toxicity profile seen, but any difference in efficacy. And to make a long story short, and not to deliberate much more about this, I think what's striking here is considering the small number of patients, there has obviously been a subset of patients that clearly benefited dramatically from the addition of this drug. You wouldn't expect these patients to respond solely to another aromatase inhibitor, considering that the median number of treatments in the metastatic setting for this patient population was 3 lines of treatment. So that included usually a couple of lines of endocrine therapy and 1 line of chemotherapy. So clearly the drug was active when added to endocrine therapy. But what's also remarkable though is when you look in here as far as PI3 kinase mutation status, there's really no difference between what was seen in patients that had a PIK3CA mutation in their tumor and the ones that didn't. So clearly, the presence or absence of mutations did not predict for clinical benefit when exposed to a pan-PI3 kinase inhibitor. So based on this initially preliminary encouraging results, at least for an overall patient population, other phase 3 clinical trials now are ongoing. There's one called BEL-2, which is for, again, second and third line patients that are randomized to either fulvestrant and placebo or fulvestrant plus buparlisib, the BKM-120 drug, with the primary endpoint being progression-free survival in each one of the different patient populations, as well as overall survival. This trial has now completed accrual, and we'll probably see some results perhaps next year in either ASCO or San Antonio. BEL-3 is a little bit of a different design, where patients still get randomized to fulvestrant or buparlisib, but the key here, and that's a different question that BEL-2 is asking, is these patients here have to have been exposed to prior mTOR. So this is a patient population that have seen everolimus before. So the question here is, can a PI3 kinase inhibitor continue to reverse endocrine resistance after somebody has been exposed to an mTOR inhibitor, which is part of the same pathway? So this trial here has not yet completed accrual. It's close, but we're probably going to see results much, much later with these trials. Now, there are other PI3 kinase inhibitors from different companies that were also being explored in clinical trials. This is a phase 2 trial that most of you may have seen in San Antonio last year that randomized patients that were resistant to endocrine therapy. They all have been exposed in the first line to an aromatase inhibitor to either receive fulvestrant with placebo or fulvestrant with piclisib, which is a pan-PI3 kinase inhibitor from Genentech. And the primary objective of this trial was also progression-free survival with overall survival as a secondary objective. And what was seen was that the addition of piclisib really didn't make any difference in the general population as a whole. And when you break it down based on PIK3CA mutation status, it didn't make any difference either. When you break it down by ER and PR positivity, however, the patients that had progesterone receptor positive cancers did seem to benefit from the addition of the drug compared to the other group. And don't ask me why was that so, like because we've been scratching our heads to try to understand what does one thing have to do with another. But be it as it may, the patient population that seems to have benefited from this was the ones that had PR positivity. One thing we could speculate in this realm is that patients that have PR positivity in addition to ER positivity in their tumors are patients that had a cancer that is potentially a lot more dependent on estrogen signaling. So because these drugs, the PI3 kinase inhibitors, they work in tandem with estrogen suppression, maybe that was a stronger signaling there, and the clinical benefit was better in this population. But be it as it may, as a whole, this particular drug did not really seem to add anything to the general population in there. Again, same thing here for like the progesterone receptor expression positivity. The benefit was seen regardless of a PI3 kinase mutation in there. Now, one thing to note about this trial that was different than all the other trials that I presented to you is that the toxicity profile seen on these patients was remarkably different than what we've seen with other PI3 kinase inhibitors. The PI3 kinase inhibitors, because of how they work, one target effect that they have, and that's invariable, that's any of them would have this as a side effect, and it's not much different than everolimus, is they all cause hyperglycemia. If you don't see hyperglycemia, it is unlikely that the drug is actually hitting the target. So in most of the clinical trials that are ongoing, or the ones that have been presented, the rates of hyperglycemia have reached 60-70% rate easily. Whereas in this trial, the rate of hyperglycemia was 17%. So one of the things that we have to wonder is this a drug that did not hit the target? And do we really need to give PI3 kinase inhibitors a bad rap based on this study? So I think right now the jury is still out if PI3 kinase inhibitors are or not going to be helpful in addition to endocrine therapy. And we do need to wait for the results of the ongoing phase 3 trials with all the other PI3 kinase inhibitors that are being explored out there. So this particular drug in this particular setting really was not helpful in this phase 2 trial. Now, there are other PI3 kinase inhibitors that are what we call specific inhibitors of PI3K, and one of them is BYL719. This is an alpha-specific PI3 kinase inhibitor. Alpha, as I said, is the subunit that for breast cancer is relevant. For those of you who are general practitioners that treat lymphomas, leukemias, whatnot, you may know that in clinical trials, the PI3 kinase inhibitors that hit the delta subunit are very relevant, especially for CLL. But for breast cancer purposes, the alpha is the one that really rules. So drugs like BYL719 or GDC0032, that is a beta sparing but has a very strong alpha activity, are drugs that are much more suitable to explore in patients that have a mutation of the alpha subunit. So we replicated a similar phase 1 trial to the previous one I showed you, but instead of using a pan-PI3 kinase inhibitor, we used BYL719. And I can't really show you this data here because this is going to be presented now at AACR, the final results, and so unfortunately this is still confidential information, but nevertheless, we've seen some interesting results with this drug and somewhat different than what we've seen with a pan-PI3 kinase inhibitor. So that led to the creation of a neoadjuvant trial that now is exploring the addition of either a pan-PI3 kinase inhibitor or an alpha-specific PI3 kinase inhibitor to endocrine therapy in the neoadjuvant setting. So this is a trial for patients with late stage 1, 2, and 3 ER-positive operable breast cancer that get randomized to either receive letrozole with placebo or letrozole with a pan-PI3 kinase inhibitor, buparlisib, or letrozole with an alpha-specific PI3 kinase inhibitor. Based on the statistical calculations of the trial, this trial should be powered to detect differences not only between the PI3 kinase addition versus not, but differences between the different PI3 kinase inhibitors that have been added. The main endpoints of this trial are going to be PET-CR, and a lot of you may be wondering, are you crazy? Like, we don't really see PET-CR with endocrine therapy in the early setting. Well, because of the way these drugs work, we are wondering if we actually may see a PET-CR difference. So that's one of the endpoints. The other endpoint, which I think is very interesting, is what we call a PEPI score, which is a collection of several characteristics that is done once the tumor gets surgically excised. So at the time of final surgery, here, we collect information on the tumor burden, so presence or absence of lymph nodes, tumor size, Ki-67, grade, and a number of other things, and that creates the so-called PEPI score. And depending on how high your PEPI score is, it tells you if your cancer really ends up needing chemotherapy or not. Think of it as a recurrence score done a little bit later in the surgically excised tumor, if you will. So this PEPI score, I think, is going to be very interesting because clearly a lot of us feel that several of our patients do not really need to be exposed to chemotherapy from the get-go, and you'd like to know if they're going to be one of the patients that has primary or secondary resistance to endocrine therapy. So I think this trial is actually very interesting because it actually allows you to make that determination after 6 months of exposure of endocrine therapy, because if these patients after this have a high PEPI score, you know you're dealing with primary resistance to endocrine therapy and these patients need chemo. Whereas if they have a good PEPI score, you know that chemotherapy is really not going to work and you can continue to safely give them endocrine therapy because they're probably going to respond well. The other thing that's interesting about this trial is this last endpoint here, where we're going to collect the surgical specimen tissue and do genetic analysis on it via next generation sequencing. And what we're hoping to find is what are the genetic mechanisms that are driving resistance after exposure to endocrine therapy. So I think this trial is, in essence, both clinical and biomarker interesting, and it's going to provide a lot of information of how these agents should be worked in the treatment of ER-positive breast cancer, either in the early or late setting. So to summarize the role of PI3 kinase inhibitors in estrogen-positive breast cancer, I would say that the PIK3CA mutations in early breast cancer is associated with a good prognosis. The pathway has a frequent mechanism, it's a frequent mechanism of anti-estrogen resistance in metastatic ER-positive breast cancer post-endocrine therapy, so it's relevant for acquired resistance. The PIK3CA mutations may be predictive of response to PI3 kinase inhibitors, especially if they are alpha-specific or beta-sparing. And the combination of endocrine therapy and PI3 kinase inhibitors may further benefit cancers that have both an ER-positive and a PIK3CA mutated cancer, but maybe not exclusively in patients with advanced stage. And I'd like to actually bring up a parallel story here, because a lot of you may be saying, well, but if these cancers do well, do I really need to add that? So many of you here treat lung cancer, and as you know, EGFR mutations in lung cancer actually confer these tumors a better prognosis overall. So if you don't treat any of these patients with anything, these patients actually have a better natural history than the ones that don't have an EGFR mutation. However, these patients have a remarkable response to EGFR inhibitors with further prolongation of survival. So the bigger question that a lot of these trials are trying to answer with PI3 kinase inhibitors is, do we have a good disease that we can make even better by adding these drugs? So this is a chapter that has not closed yet, and I think we still have to wait for a lot of these clinical trial results to see where these drugs are going to fit in the future landscape treatment of ER-positive metastatic and early breast cancer. So now I'm going to switch gears and talk a little bit about the CDK pathway. So CDKs are actually regulators of the sequential progression that the cell cycle goes through, G1, S, S2, and M, all these phases of the cell cycle. And essentially what they do is they interrupt cell cycle. I like to simplistically think of them to some extent as a mini chemotherapy. But be it as it may, these drugs there are several CDK4 inhibitors in clinical trials right now. And one of them has actually been approved, and we'll talk a little bit more about them and how is this relevant for ER-positive disease. So one of the things that we have to have in order for the CDK inhibitors to work is presence of a molecule called RB. So RB is a downstream target of CDK4, and you need that present there in order for CDK4/6 inhibitors to work. When in RB-competent tumors, this therapeutic inhibition of CDK4/6 blocks this phosphorylation of RB, and that reactivates and maintains the tumor suppression function that RB has. So you essentially, you're not only stopping cell cycle, but you're doing that through RB. So the reason that's important is because theoretically, these drugs would only work in tumors that have RB intact. In ER-positive breast cancer, most of them, the vast majority of ER-positive breast cancers have RB intact. The tumors that don't have RB very intact, as you may guess, are triple-negative cancers. So in that patient population, it's questionable if medications like CDK4/6 inhibitors will play a role. They may, but that remains to be seen. But the preclinical data and what we know genomically about these cancers suggests that that would not be the case. And that's actually further corroborated by the TCGA breast tumor RB pathway analysis, where you can see here that, again, the luminal A and the luminal B tumors have actually activation of RB. RB is intact, where the basal-like ones, RB is actually not working. And that's not just presence by immunohistochemistry, that is actually genomically driven data or loss of heterozygosity data. So, let me see. The other thing you can see here is that when you expose different types of cell lines to a CDK4/6 inhibitor, what you see is when you do this one here, which ultimately becomes palbociclib nowadays, the response in ER-positive cancers and to a lesser degree HER2-positive subtypes is much more pronounced in the cell lines here that are luminal. meaning the estrogen receptor positive cell lines. So they actually respond very, very nicely to CDK4/6 inhibition, whereas the non-luminant ones do not. So that's the preclinical basis for bringing these compounds into clinical trials. The first clinical trials that were reported with clinically meaningful data with CDK4/6 inhibitors are the series that we call PALOMA. The PALOMA-1 trio trial was actually a compilation of the data of these two clinical trials that essentially had identical design. To make a long story short, these are all women in first-line treatment of metastatic disease that were randomized to receive either letrozole or letrozole plus palbociclib, which is a CDK4/6 inhibitor. So if you initially, this population was unselected, and then they did select for presence of CCND1 amplification or loss of P16, which they at that time thought were going to be predictive markers of response to these drugs. So if you add these two numbers here, 66 plus 99, you get the 165 patients that led to the approval of this drug now by the FDA based on this data here. The interim progression-free survival was actually quite impressive for the addition of palbociclib to endocrine therapy in first-line treatment of estrogen receptor-positive metastatic breast cancer. The overall survival trends that way, and we are now waiting for the results of the PALOMA-2 trial, which is this one here, which randomizes patients. It's a phase 3 trial that randomizes patients in first line to receive either letrozole or letrozole with palbociclib. So letrozole placebo versus letrozole palbociclib. Results of PALOMA-2 should potentially be expected either by, I don't think by ASCO, but definitely by San Antonio of this year. So that will either confirm what we've seen with the phase 2 studies or disprove that, and then the FDA will have to explain themselves of why did they approve the drug without having the phase 3 study results available. There are now clinical trials looking at this at a later line. So this is for PALOMA-3, explored the CDK4/6 inhibition after patients have been exposed to an aromatase inhibitor in the first-line setting. So this is second and third-line treatment. And there are now other trials that are being done via the Translational Breast Cancer Research Consortium and the Spanish group looking at what we call palbo after palbo. So patients that have been exposed in first-line to palbociclib and then re-randomizing them for continuation of CDK4/6 inhibition, but you switch the endocrine therapy. So more to come on those trials. But in the big scheme of things, a lot of people ask me, well, now that palbociclib is available, are you using it in everybody? And the answer to me is still no. I am not yet quite sold that this is actually a strategy that should be used for everybody, because just like with the Bolero data, there are going to be patients that are going to benefit tremendously still just from endocrine therapy in first line. So if you have a woman who wants to preserve her quality of life, does not want to come in for frequent blood checks because God knows that this drug does cause severe myelosuppression, and does not want to deal with GI toxicities and whatnot, it's still appropriate to use endocrine therapy first line by itself without necessarily adding palbociclib. But if you have a patient that looks like she has what we call that primary endocrine resistance, meaning they recurred very quickly while they were in the adjuvant setting, it may be appropriate to consider this, because this is a drug that potentially will be more impactful for patients that don't have a great response to endocrine therapy. Now there's other strategies look within this realm where we are now looking at potentially combining CDK4 and PI3 kinase inhibition to estrogen therapy for patients with ER-positive metastatic breast cancer. And there's an ongoing trial. The phase 1 trial is about to be completed, and the randomized phase 2 is going to look somewhat like this, where patients are going to be randomized in first line to receive either letrozole with a CDK4/6 inhibitor, LE011, or letrozole plus a PI3 kinase inhibitor, or letrozole with both. So more to come on that. This trial has not started yet, but again, I think this probably be a much more relevant strategy for patients that have primary acquired resistance to endocrine therapy rather than the ones that have secondary acquired resistance. And now switching gears again, we'll talk a little bit about methylation. So methylation is pretty much a black box that a lot of people don't understand well. But essentially what this means is that methylation regulates how genes work. So you don't necessarily see amplification or mutation or a gene alteration per se, but this methylation may turn on and turn off a lot of these gene activities. And when you use an HDAC inhibitor, what you could potentially be doing in cells that have estrogen positive expression is the HDAC inhibitors can open up the DNA structure, so it goes from here back to here, and that enables the transcription of ER. So by potentially using endocrine therapy plus an HDAC inhibitor, you could be making the cells respond again to estrogen suppression once they become resistant. So one clinical proof of that is the study, this phase 2 study called ENCORE 301, which randomized patients with ER-positive metastatic disease post-AI progression to either receive exemestane plus placebo or exemestane plus entinostat, which is an HDAC inhibitor. And so far what we've seen is that the median progression-free survival and the trend towards overall survival has been actually incredibly promising with the addition of entinostat to this group of patients and endocrine therapy. So now ECOG actually has a study called EA 2112, which is being done through the intergroup, which is a phase 3 study randomizing patients post-AI exposure to receive exemestane plus minus entinostat, looking at progression-free survival and overall survival as an endpoint. So more to come on that. I think this is definitely a promising strategy. It's one that's like somewhat outside the box of what we've done so far and probably a very important avenue to explore. So, to summarize a lot of what we talked about today, what could the future treatment landscape for ER-positive metastatic breast cancer may look like? So what it may look like is that for first line, we may end up using endocrine therapy with a CDK4/6 inhibitor. For second line, we may be using endocrine therapy either with a CDK4/6 inhibitor or with a PI3 kinase inhibitor or with an HDAC inhibitor. And obviously we can't forget that there's going to be even more clinical trials coming about and other pathways that may be explored, such as FGFR inhibition or RK inhibition and whatnot. But I think in the big scheme of things, the big take-home message of the talk today is we have all these things available. It doesn't mean that just because we can use it, we should use it on everybody. I think the big take-home message is you still need to individualize treatment for your patients. When you have a patient that, again, what that patient cares more about is her quality of life, and they seem to have, biologically speaking, a tumor that behaves well, it's absolutely not wrong to just stick with good old endocrine therapy, because ultimately that's what these patients are going to respond to. So I'm thankful that these drugs are there. I'm thankful that there are options for our patients, but I don't think everybody on an individual level are going to behave from the addition of these drugs. And in the big scheme of things, I'm still a little unenthusiastic by the fact that none of these drugs so far have actually showed survival advantage for these patients. So they are all options. They're all great options, but use them judiciously. Not everybody has to be exposed to all of this. And with that, I'm going to finish by saying that thankfully numerous clinical trials are addressing these unmet therapeutic needs in patients with ER-positive metastatic breast cancer that unfortunately still die of their cancer and progress on existing therapies. All these novel treatments will really need to be individualized based on de novo and acquired resistance, which I think are key in order to help you make decisions of when are you going to add what. You have to take treatment goals into consideration, and to me that's the main thing. And nowadays that we can potentially profile some of these tumors, I think participation in clinical trials that are led by some of these mutations we may find on these tumors is a very interesting avenue. And obviously that would lead us to better understand all the signaling crosstalk pathways that may lead to additional targets and development of more targeted agents that we can combine with endocrine therapy either sequentially or in conjunction with it to overcome this mechanism of resistance and improve outcomes overall. And with that, I'm going to finish, and I hope I'm not too late, and I think we have a little time for questions. Thank you.